All right. Happy Thursday, everyone. Welcome to today's webinar, Risk Standardized Survival and High Quality CPR for Get With the Guidelines Resuscitation. My name is Natalie Navarre. I am the Senior Program Development Manager for Get With the Guidelines Resuscitation. Before we get started, I'd like to go over just a few items so you know how to participate in today's event. This webinar is being recorded and will be sent out via email within 24 hours. There are no CEs associated with the webinar, but you may access a certificate of completion in a follow-up email after the event. You can type questions into the questions pane of the control panel on the right side of your screen at any time. We will collect these and address them if time allows. If you experience any technical issues during the presentation, please try refreshing your browser. Otherwise, refer to the GoToWebinar customer service team, whose contact information is in your webinar confirmation email. There is live closed captioning via the hyperlink in the chat. Next slide. The AHA's 5 inpatient Get With the Guidelines programs, including Get With the Guidelines Resuscitation, promote adherence to the latest research-driven guidelines and provide data and reporting capabilities to drive continual improvement in patient care. The QR code on the screen will allow you to request further information on all of our programs. Next slide. Our presenter today is Dr. Paul Chan. Dr. Paul Chan is Professor of Medicine at St. Luke's Mid-America Heart Institute. He completed an undergraduate degree in chemistry and religion at Harvard, a medical degree at Johns Hopkins, and a combined internal medicine and pediatrics residency at Harvard's Brigham and Women's and Boston Children's Hospitals. After working on the Navajo Reservation for 4 years in Northeast Arizona, Dr. Chan completed a master's in biostatistics and an adult cardiology fellowship at the University of Michigan. Dr. Chan spends 2/3 of his time conducting clinical research and has over 300 peer-reviewed publications, publishing extensively on epidemiology, outcomes, and quality of care for both in-hospital and out-of-hospital cardiac arrest. In collaboration with the AHA, Dr. Chan helped develop the methodology to calculate risk-standardized survival rates for in-hospital cardiac arrest for hospitals and Get With the Guidelines Resuscitation. Dr. Chan is also the chair of our Get With the Guidelines Resuscitation Volunteer Clinician Advisory Group. Next slide. Our moderator today is Dr. Monica Kleinman. Dr. Kleinman is a pediatrician and critical care specialist serving as Associate Chief of the Division of Critical Care Medicine at Boston Children's Hospital. She is also Chief Safety Officer for the Program of Patient Safety and Quality, co-chair of the Resuscitation Quality Program, and Associate Professor of Pediatric Anesthesia at Harvard Medical School, where she is deeply involved in medical education and research. Board certified by the American Board of Pediatrics in Critical Care Medicine, Dr. Kleinman's expertise spans neonatal to perinatal medicine, pediatric critical care medicine, and critical care medicine. She earned her medical degree from Brown University. Throughout her career, Dr. Kleinman has been dedicated to advancing pediatric resuscitation science and improving patient safety. Her multifaceted role as a clinician, educator, and researcher underscores her commitment to providing exemplary care to children and their families. Dr. Kleinman is also a member of our Get With the Guidelines Resuscitation Volunteer Clinician Advisory Group. Thank you both so much for being here. Dr. Chan, you can take it away.
Hi, everyone, and thank you so much for the opportunity, Natalie, for sharing the award system, the 2 new awards that we'll be discussing on our webinar today. For both Dr. Kleinman and myself, we do not have any conflicts of interest or disclosures for the purposes of this talk. So our objectives in my presentation for the next 30 to 35 minutes before the question and answer session is to describe the 2 new Get With the Guidelines Resuscitation Awards. The first is an award focused on survival to discharge for patients with in-hospital cardiac arrest, and what we're calling the risk standardized survival rate at the hospital level for in-hospital cardiac arrest. And I'll go over why we need risk standardized survival rates for hospitals and the impact of COVID-19 since 2020 on in-hospital cardiac arrest survival, and what we have subsequently done to revise the risk standardized survival rates model as a consequence of this. Secondly, we'll be discussing the new measure on CPR quality measurement, which will be important for informing future evidence-based guidelines for resuscitation and also for incentivizing quality improvement within your own hospital. So to start off, why do we even need to risk standardize survival rates for in-hospital cardiac arrest? And the first thing I would say is risk standardization is a statistical term. The best way to think about risk standardization is we're risk adjusting for the patients who have a cardiac arrest in your hospital when we compare hospitals' survival rates. As you know, Get With the Guidelines resuscitation has been around since 2000. So for 24, 25 years, it was initially named the National Registry of CPR and then renamed Get With the Guidelines resuscitation under the suite of registries under the AHA. And over the past 24 years, we have collected, or you have collected, over probably close to 600,000, 700,000 in-hospital cardiac arrest cases from a number of hospitals around the country, over 800 different hospitals. One of the first papers that came out of the registry after the first decade was understanding how we are doing across hospitals around the country in survival rates for patients with in-hospital cardiac arrest. And this paper was published in the New England Journal of Medicine in 2012. And what our colleagues did in this paper was to really look over the first decade of the registry, what's going on with survival rates. Now, these survival rates are simple proportions. They're not adjusted. And I will focus you on the blue diamonds, which is all the pulseless cardiac arrest cases that we have. They comprise the systole, PEA arrest, ventricular fibrillation, and pulseless ventricular tachycardia. And you can see that overall, from 2000 to 2009, the rate of survival to discharge has gone up from about 8% in 2000 to closer to 15% by the time we hit 2009. And when we broke it up to the shockable and non-shockable rhythms for VF and pulseless VT, and I should point out this is a study on adults 18 years of age and older, it went from below 30% to close to 40%. And for asystole and PEA, it went closer to 6% in 2000 to about 10% in 2009. And if we actually projected out this graph for another decade, from 2010 to 2019, we know that the blue diamond shape, the overall rate, had gone up as high as 25% as of 2018 and 2019. So we've made dramatic improvements in how patients do. It is no longer viewed as futile, and 1 in 4 patients with an in-hospital cardiac arrest is leaving the hospital alive if they're an adult. And so there's been great interest as survival rates have increased at the patient level to understand how hospitals are doing as an entity unto themselves. Now, most of you are familiar with the module where you enter data of your patients with in-hospital cardiac arrest, and you can query your data to understand what your overall survival rates to hospital discharges for your hospital. You get a numerator and you get a denominator, and if you had 100 in-hospital cardiac arrest cases and 23 patients survived to discharge, your overall survival rate would be 23%. But how do you make sense of a 23% survival rate if you're looking and comparing with other hospitals around the country and other hospitals within the registry? And so previously, hospitals were sharing or comparing results with one another potentially and trying to gauge whether or not they're doing what other hospitals are doing in terms of survival. But these results or these comparisons were essentially unadjusted and really didn't take into account differences in the patient population that may be a reality on the ground when you're looking at your hospital versus another. And I've shown this for people who've attended this webinar before, but you have 2 hospitals. These are made-up data, but they both have 100 in-hospital cardiac arrests. And Hospital A had 30 surviving the hospital discharge, or a survival rate to discharge of 30%. And Hospital B had 40 survivors out of the 100, or 40% survival rate to hospital discharge. And on the surface, without risk adjustment, one would potentially argue that Hospital B had a higher survival rate, 40% versus 30%. If one delve deeper, just looking at the shockable versus non-shockable ratio, you see for Hospital A, 20% of their cardiac arrest cases were shockable, but 80% were non-shockable, which tend to have a lower survival rate than the shockable cardiac arrest cases. And hospital B had, in this hypothetical example, the reverse, 80% shockable and 20% non-shockable. And so when you parse this out on the shockable versus non-shockable level, it's the same data. Hospital A still has a 30% overall survival rate to discharge, and Hospital B has 40%. But for the shockables, Hospital A has a 70% survival rate as compared to Hospital B, which has a 47.5% survival rate for the shockable arrest. And then if you look at Hospital A's non-shockable survival rate, it was 20% as compared to Hospital B that had a non-shockable survival rate of 10%. It then becomes clearer that actually Hospital A, which only had a 30% overall survival rate, is actually having a better performance in survival outcomes when you stratify it based on the shockable versus the non-shockable rhythms. And one can do the same by looking at age differences, by comorbidity differences, by how sick the patients are at the time of their in-hospital cardiac arrest. And so that's one of the reasons why it was important to start developing a measure to risk standardize survival rates to hospital discharge for patients with in-hospital cardiac arrest so that we can compute, if you will, a risk-adjusted survival rate for your hospital compared to the hospital across town in your city or in a different state in the United States that's participating in Get With The Guidelines resuscitation. It provides essentially an apples to apples comparison of very similar patients with similar comorbidity and demographic case mix, as well as what types of interventions are in place. Are they mechanically ventilated, what their initial rhythms were, where their location of arrest was, which can play a huge role in predicting survival. And to do this, we basically, on the back end, created a fancy model, what we call a multivariable model. And we're able to then calculate for each hospital what their risk-adjusted or risk-standardized survival rate for in-hospital cardiac arrest would be. And this initial model that we published was published in, I think it was in 2012. And for the adult population 18 years of age and older, we identified 9 key predictors that are the strongest predictors of survival to discharge outcomes for patients within hospital cardiac arrest. There are other predictors that were significant, but to create a reduced model, these 9 were the ultimate ones that were retained in the risk standardization model. And they include the age of the patient, not surprisingly, because older patients are less likely to survive regardless of what condition one has. The initial cardiac arrest rhythm, the location of the arrest, whether the patients had hypotension within 24 hours of their cardiac arrest, sepsis, a metastatic or hematological malignancy, hepatic insufficiency, and whether they were mechanically ventilated or an IV vasopressor infusion at the time of their arrest. We did the same for the pediatric population, and this is specific just for those who take care of children on the call for pulseless, initially pulseless in-hospital cardiac arrest. So we're talking about asystole, PEA, VF, and pulseless VT. And there were 13 key variables in the pediatric model, a lot of them similar to the adult model, but again, age, sex, illness category, hypotension, renal insufficiency, metabolic or electrolyte abnormality, acute non-stroke, CNS event, septicemia, major trauma, mechanical ventilation, intravenous vasopressor, location of the arrest, and initial cardiac arrest rhythm. For folks on the call, just so you know, we're in the process of developing a new measure for risk standardization for children that will incorporate initial bradycardia as well as the 4 other pulseless rhythms. And that will be forthcoming hopefully in the next year. So before risk standardization, and in any given year, this is one sample year, you see a range of unadjusted survival rates. You have hospitals with survival rates that are unadjusted, that are on the lower end, and some hospitals on the higher end. Now, some of you may notice there's a lot of hospitals with unadjusted survival rates of greater than 35%. Most of this is driven by a number of hospitals that don't have a lot of cardiac arrest cases. And so you can imagine if a hospital only submitted 2 or 4 cardiac arrest cases and 1 or 2 patients survive to discharge, they have an unadjusted survival rate of 50% or even 100% if they had 2 cardiac arrest cases and both of them happen to survive. But after risk standardization, we have a normal distribution curve. And one should keep in mind that when we risk standardize, not only does it risk adjust for the comorbidity differences across patients, but it also takes into account how many arrests are submitted by each hospital to calculate to compute the risk standardization rate for survival for each hospital. So if a hospital had only 1 or 2 cases, they're unlikely to have a risk standardized survival rate that's going to be in the upper end because of what the model does with what we call shrinkage estimates. It's a statistical term that basically says there's a lot of uncertainty about what the true risk standardized survival rate for that hospital would be because they only contributed very few cases for that calculation. The risk standardized survival rates have been reported to Get With The Guidelines hospitals since 2012. So every year, your hospital has the ability to pull up its risk standardized survival rates. The risk standardized survival rates are usually calculated in May. The data from, let's say, 2023 were cleaned by AHA and their team in March. And then the risk standardized survival rate is calculated. It takes about a month. And by the time May rolls around, those are brought back to the AHA, and oftentimes those will be shared with you between May to June of each year. They have been historically on the Get With The Guidelines site, and you can see the My Report section on the Get With The Guidelines interface and pull up the report. And what the report is sharing with you each year is the first page is a summary page, again, reminding you and others what the risk standardized survival rate is and what kind of variables are accounted for in the risk standardization. If it's adult hospital, it will be the 9 variables initially and the 13 variables subsequently in the revised model. And if it's pediatrics, it's 13 variables as well. When you click on that report, this was a sample from 2012, site number 1354, so it's de-identified. The risk standardized absolute survival rate was 19.7%. So basically, after risk standardization, 1 in 5 of their in-hospital cardiac arrest patients survived to discharge. And they were put in category quintile 1. What does that mean? Well, quintile 1, it's a reminder, it's very similar to like the reading and math sort of percentile scoring system that you may see from your children. Basically, quintile is it's broken into fifths. So quintile 1 are hospitals that have risk standardized survival rates when ranked between 1% to 20%. If you're in quintile 2, it's ranked 21 percentile and to 40th percentile. And then the highest surviving quartile is quintile 5, and their percentile ranking 81% to 99th percentile in terms of the performance for that year for risk standardization of survival to discharge. In this report since 2012, we now have the capability of providing you your hospital's risk standardized survival rate every year. So not only are you getting, let's say in 2023, your risk standardized survival rate on the far right here with the triangle, but you can see how your hospital has been doing year over year. So that's the first thing that you can glean from the risk standardized survival rate plot. Is my hospital improving from the last year, and what has it been doing year over year over the last however many years your hospital has been participating in Get With The Guidelines resuscitation since 2012. We also plot for every year the maximum, and you can see this dotted line above the triangles, and the minimum. And then the middle shaded area is where we have the hospitals in the middle 3 quintiles. So if you're 21st percentile to 60th percentile, your hospital will fall in this gray shaded area. And it gives you a very quick way to glimpse whether or not your hospital is in the top quintile. So if you're above the shaded area, as in this hospital for every year, or if you're in the lowest quintile, if you're below the shaded area. What I share with folks around the country is if your hospital is in quintile 1 or 2 or 3, 4 or 5, it doesn't matter where you start off. The first thing I would ask hospitals to look at is how is your hospital doing year over year compared to last year, compared to 2 years, 3 years ago? Because your ability to gauge the graph of your hospital's risk standardized survival rate gives you a sense as to whether or not your hospital is improving in and of itself. The risk standardized quintiles are in many ways a comparison or a benchmarking of how your hospital is doing over time in a given year. But it's hard for a hospital that starts, let's say, in quintile 1 to move to quintile 5 in 1 year. But what you want to see is gradual improvement year over year. What we notice in 2020, and many of you experienced this firsthand, is that COVID has introduced tremendous changes in survival rates for patients with in-hospital cardiac arrest. And survival rates have decreased within the registry for in-hospital cardiac arrest. When we looked back at the risk standardized survival rate in 2018 and 2019, it was pretty much at 25 to 26% across on average for hospitals within the registry. In 2020, it dropped to slightly below 20%. So that's a huge drop of 5 absolute percentage points when it took us essentially a decade to increase by 5 percentage points. And this is a study Saket Giroltra and some of our colleagues published looking at the association of COVID-19 infection with survival after in-hospital cardiac arrest during the first 10 months of the pandemic. We looked at data from March to December 2020. There were basically 25,000 patients that year during those 10 months after the pandemic emerged in the United States. Those patients within hospital cardiac arrest, and about a quarter of them, 5,916, had suspected or known COVID-19 infection. And we saw that patients who had an in-hospital cardiac arrest and COVID were younger and more often were male, were sicker with many of the comorbidities than non-COVID patients, and oftentimes were mechanically ventilated and on pressors more so than non-COVID patients. And this is every month in that 10-month period. The top graph is the not patients without COVID. You can see the survival rates to discharge range month to month between 21 to 25%. And if you had concomitant COVID with your in-hospital cardiac arrest, it dropped to as low as 10% in April and as low as during that Delta wave in December of 2020 to below 10%. But in every month, it was lower than patients who did not have COVID and had in-hospital cardiac arrest. And so when we risk adjusted between COVID and non-COVID patients, we found that patients with COVID-19 during those 10 months had a rate of ROSC of 54% compared to 64% among patients without COVID. And you can see that even after risk adjustment, their odds, the relative risk of having ROSC was 0.86, which means they were 14% less likely to achieve ROSC if you had COVID. And survival to discharge was even more dramatic. It was half, 12% for COVID patients, 24% for non-COVID patients, and even after risk adjustment, the relative risk was 0.65, which means that COVID-19 patients with cardiac arrests were 35% less likely to survive than non-COVID patients after risk adjustment, since they were younger, for instance. And so as a result of this, we have updated the risk standardization model for survival to discharge for the adult population. We took 2 years of COVID data, 2020 and 2021, and we basically did the whole process again of deriving and validating the model. And this model now has 13 variables and includes the variable COVID-19 infection. And you can see that the odds ratio in this model is 0.34. So if you had COVID in the risk standardization model, if you have COVID and an in-hospital cardiac arrest, your expected likelihood of surviving the discharge is 66% lower odds compared to a patient without COVID. And again, from that new updated model, you can see It's a normal distribution curve for 2020 and 2021, and this is at the hospital level. So we have 372 hospitals in this analysis. The means risk standardized survival rate was 21%, and what we call the lower quartile, or the 25% range, is 18.1%. The 75% range was 23.8%, but you can see some hospitals with risk standardized survival rates above 30% even. This is just to make sure that our model predicted well. It's what we call calibration, and therefore what we do here is just make sure that the model is doing what it's supposed to do. And if it is doing really well, it should approximate 1.0, and the calibration R-squared was 0.995, so pretty close to 1.0, suggesting that the model had great calibration. So regarding the risk standardized survival rate measure, in discussion within AHA and Get With The Guidelines resuscitation, it was felt that while we had the awards measure for processes of care, which you guys have been part of with the gold, silver, and bronze medals that include metrics like time to defibrillation, time to epinephrine, and time to CPR, and other components, we are beginning a survival recognition measure for 2024 data, which will be announced in 2025. Hospitals in the top 2 quintiles of risk standardized survival rates each year will now receive the award for survival recognition, irrespective if they received the process of care award measure. So it's an additional measure that recognizes hospitals that ultimately bring to bear the outcome most important to your patients, which is surviving and leaving the hospital alive, which means that the top 40% of hospitals for survival every year with this award will be recognized for the survival measure. I'm going to just pivot now to the second award, which is the CPR Quality Award. As many of you know, the guidelines really hammer the importance of high quality CPR during resuscitation, along with prompt defibrillation for those with a shockable rhythm, as 2 of the most effective interventions to improve the odds of patients surviving, not only achieving ROSC, but surviving the hospital discharge when they have a cardiac arrest in the hospital setting. And so, again, the AHA and Get With The Guidelines resuscitation deliberated and are beginning to introduce this CPR Quality Award with calendar year 2024 data to be announced again in 2025 on hospitals that meet certain thresholds. And it's really based on whether a hospital for its in-hospital cardiac arrest cases are abstracting data on CPR quality for at least half their patients within hospital cardiac arrest. So if you have 100 patients for 2024 that have in-hospital cardiac arrest that you're submitting, and 54 of them you submit some of the metrics that is going to be counted as CPR quality, you will meet the threshold for this award. The metrics include submitting data on compression rate, compression depth, compression fraction, or physiological monitoring with either end-tidal CO2, arterial waveform, diastolic pressure measurement. You do not have to submit all 4 of these for each individual in-hospital cardiac arrest patient, although we would ideally recommend that you do. Ultimately, what for this year, the 2024 measure is that any of these 4 will meet the criteria. The CPR quality, as you may know, this is a snapshot of the paper form. There's a question of CPR quality, and it asks whether performance of CPR was monitored or guided using any of the following. And the things that will count for this CPR award for 2024 is if the waveform capnography or end-tidal CO2 is checked, or the arterial waveform diastolic pressure is checked, or if you use a CPR mechanics device, which you would check as a third option, if you enter data on compression rate, depth, or compression fraction. Ideally, if you're entering compression rate, you would also be able to enter the information on compression depth and compression fraction as well. And the rationale for the CPR Quality Award is the following. For compression depth, there has been some reviews, in this case done by ILCOR in 2020, of 12 studies comprising over 12,500 patients. And several of the studies found that patients who had compression depth of 5 centimeters or greater had better or higher survival to discharge rates and defibrillation success as compared to patients with compression depths of 4 centimeters or lower or less. For compression rate, it was the same review from ILCOR in 2020, identified 13 studies, and there's currently no evidence to suggest that we should alter the suggested and recommended compression rate of 100 to 120 chest compressions per minute in adults. 3 studies did find that as the depth decreases, that compression depth decreases as the rate increases, highlighting the potential pitfalls of evaluating just a single CPR quality metric in isolation. And that's why there's an emphasis in gathering information on depth and rate. And finally, compression fraction really aims at looking at how great are the interruptions in CPR during a resuscitation for a patient within hospital cardiac arrest. We know if we can minimize interruptions, that the survival odds are improved. And there are studies to inform that as well. Ultimately, by gathering information from all of you that you guys are collecting and taking care of these patients, we're hoping that in the future, as this information becomes collected in aggregate, we may be able to actually identify and inform new evidence-based recommendations for guideline development. There are also studies that suggest that the actual act of physiological monitoring during CPR can be potentially critical and important in optimizing survival outcomes for patients within hospital cardiac arrest. There actually was a Get With the Guidelines resuscitation analysis finding higher likelihood of ROSC when CPR was monitored with end-tidal CO2 or diastolic blood pressure measurements. There was another observational study in adults that found for every 10 millimeter of compression depth increase, end-tidal CO2 increased by 1.4 millimeters of mercury. There have been also systematic reviews of the importance of end-tidal CO2 as a prognostic indicator for ROSC, that when you have end-tidal CO2 measurements of less than 10 millimeters of mercury, it's associated with poorer outcomes. When it exceeds 20, it's associated with higher likelihood of ROSC. And then there are studies that have been done to suggest that the use of monitoring diastolic blood pressure during a cardiac arrest is associated with higher ROSC rates. But there are currently inadequate human data to suggest any pre-specified parameters. So what I wanted to do is really spend these 30 minutes to share with you the exciting awards that Get With the Guidelines Resuscitation is putting forth to really, again, push the envelope forward, to move the market, to try to incentivize hospitals to look at survival rates as an important outcome and not just the award process of a care measures that you guys have been getting awards for. And then also how important measuring CPR quality can be ultimately in allowing hospitals to inform what their CPR quality may be and how they can actually do quality improvement in the future. And let me stop there, and we'll have some time for questions and answers.
Thank you so much, Dr. Chan. As you mentioned, we will now move on to our moderated Q&A with Dr. Kleinman.
Dr. Kleinman, if you're on mute, you might have to unmute.
You can go ahead, Dr. Kleinman.
I think you're still on mute, unfortunately.
Technical difficulties. 1 second while we try to get Dr. Kleinman off mute.
Okay, how's that?
Great.
Got you, yes.
Sorry, it would not allow me to unmute myself. Big Brother must have been watching. Paul, thank you for that. That was incredible run through of 2 really important new awards that I think are going to be exciting for those of us who participate in Get With the Guidelines resuscitation. And the first thing I wanted to ask you about, we all do a lot of metrics. We certainly measure probably more than we utilize, but it seems to me that there's a little bit of a shift here, as we've seen with other registries and with other performance measures in looking at outcomes, not just looking at process. And I think your work has really lifted the field, particularly in pediatrics. Thank you for that, to give us a way of looking at outcomes that we haven't been able to look at before, not just raw survival rates, but risk adjusted. I wondered if you could comment on sort of what led you to look at this, and how you were able to also accomplish this for pediatrics, which is such a heterogeneous group of patients based on age and risk factors.
Yeah, thank you, Dr. Kleinman. One of the impetus for looking at survival rather than processes of care is we know that the care of our patients within hospital cardiac arrest does not end at the time of ROSC. And there's a lot more that goes on after somebody has returned to spontaneous circulation, and that's driven partly by post-resuscitation care. And we also know from out-of-hospital cardiac arrest randomized trials that getting ROSC does not necessarily translate to higher rates of ROSC, like with high-dose epinephrine trials, does not translate to better survival. And so the thought was that if we're focusing on just the resuscitation, which is very critical, I mean, we want patients to get defibrillated ASAP. We want patients to get epinephrine when appropriate for non-shockable arrest within the first 5 minutes. And we want time to CPR to be really instantaneous when somebody identifies an in-hospital cardiac arrest. But we know that ROSC rates don't always mean better survival rates. And that is one of the main drivers of thinking about survival to discharge as an additional measure to think through. We want to improve our processes during resuscitation, no doubt. And that is really the formative foundation for Get With Guidelines resuscitation. But and part of that journey was we were finding hospitals when we were doing some of our site visits for an NIH grant that actually were achieving very high survival rates, but they were always miffed or sort of confused why they were never able to achieve the award measure. And they had excellent post-resuscitation care, for instance. And so that was really some of the reasons why we started thinking, well, maybe we need to also additionally look at survival outcomes, because we're only looking at half the puzzle with ROSC or with processes of care. And so really mirroring the intra-resuscitation and post-resuscitation components of care was really the inspiration for thinking of survival as an important outcome to also drive home for hospitals. And also because it's really the outcome most important to patients. Clearly, there's a link. If you get defibrillated promptly, you're more likely to survive to discharge. But if the post-resuscitation care is not high quality, it doesn't matter, if you will, or it doesn't matter as much if the defibrillation was prompt. For pediatrics, it's a lot trickier. You're very, very correct on hitting on that. What I mean by trickier is that pediatric patients run the whole gamut from neonates to 17-year-olds. It's a lot more different than comparing a 37-year-old with a hospital cardiac arrest and a 70-year-old, both in terms of the cause of the arrest and also the types of potential responses. The other challenge with pediatric data is that we just don't see a lot of postless in-hospital cardiac arrests unless you're a dedicated pediatric children's hospital. And so a lot of hospitals that submit pediatric data may have on any given year 1 to 5 in-hospital cardiac arrest cases. And so that becomes a lot harder to really, even with a good model, to pinpoint with great accuracy, especially with the heterogeneity in pediatric patients to begin with, the risk standardized survival rate. And that's one of the reasons why we want to look at the non-postless bradycardia CPA events in pediatrics, because they actually outnumber the postless in-hospital cardiac arrest events. And if we're able to increase case volume and also account for the fact that they're bradycardia and not a postless arrest, we can provide much more informed information in the future for the risk standardized survival rate for pediatrics. Currently, and I didn't mention this in the talk, the pediatric risk standardized survival rate is 2 years of data and not 1 year of data. That's the case with adults. It's every year we calculate separately. For 2024, we're going to calculate 2024 data for adults, but for pediatrics, it's 2023 and 2024. So for hospitals that are submitting and looking at their pediatric risk standardized survival rate, it's going to take longer to change your risk standardized survival rate, because every year that we're calculating it, it includes the year before. And so you're only changing half the patient case numbers because the year before, so like this year we calculated 2022 to 2023. Next year will be 2023 and 2024. So 2023 is in the calculation for both years.
Understood. I want to thank you for explaining that as a non-statistician. I'm really in awe of your formulas and the statistical explanation and boiling it down to us as something that is important for everyone who works in the QI space, whether it's your bloodstream infection rate, whether it is your fall rate, whether it is your resuscitation success rate. We all know that risk adjustment is crucial to interpreting the data and helping us to understand whether or not we're comparing, as you said, apples and apples versus apples and oranges. So thank you for your contributions. One question I had was certainly within a hospital, it will be helpful to do your risk stratified survival rate. Is there any plan to be able to anonymously compare with other institutions, either on a voluntary basis or in a way that the AHA would allow? This is a bit of a double-edged sword. I think you can see pros and cons to it, but many people who work with Get With The Guidelines are asked the question, how do we compare to other institutions?
Right. So right now, the risk standardized survival rates, let's take the case of adults, it's calculated for the 300 to 400 hospitals participating every year and submitting adult data. It is possible, and I'll defer to the AHA in the future to do this. They could, you'll have your quintile ranking. They could then look and provide the quintile ranking for just academic hospitals, for hospitals of a certain size of beds. That's very, very easy to do. And I think part of the challenge is we could create those graphs for academic versus major, minor, and non-teaching hospitals, for hospitals of different bed sizes, census regions. We want to make sure that the key message is that they see the first risk standardized survival rate, which is their absolute survival rates, standardized survival rate amongst the 300 to 400 hospitals. But it's very doable to provide it in the context of substrata based on hospital characteristics. And again, this is the data, the calculations are provided to the HA and in a way that they could easily do that if they want to. And I defer, whether or not this is usable or it's something that they want to consider in the future.
Thank you so much. With regard to the CPR quality metrics, which I know are, for the past 10 to 15 years have certainly been the bedrock of guidelines and the importance of following those CPR quality metrics. And then most recent iteration is trying to translate those into more physiologic-based data. One of the things I wanted to mention is that there are some limited data on pediatric patients in terms of end tidal CO2 goals now as well, which is a goal of an end tidal CO2 to be achieved of 20 millimeters of mercury, and some very interesting data on diastolic blood pressure targets that actually were incorporated into the 2020 guidelines based on some very elegant work out of CHOP, where they looked for infants and children at threshold diastolic blood pressures associated with improved survival. Is there any intention to try to gather some of that data, meaning some of the physiologic data, not necessarily the raw data, but the specific targets?
Right, and I think that the intent of the metrics that are outlined in the CPR quality is what is the targeted compression depth or compression rate during the resuscitation. If that is the data that is going to be collected, it potentially provides an avenue for developing research in looking at in the real world practice across many hospitals, how that plays out in terms of survival outcomes. The real challenge, of course, is, and I don't collect this data personally. I'm not the abstractor in my hospital, but how accurate is the data that can be collected on this type of information if the abstractor is collecting it not in real time? And what that would require is that for the codes that are run, that individuals in the hospital know to document what those parameters are as accurately as possible. Because without doing that, an abstractor coming back to an in-hospital case 2 weeks later will not find that information.
Yeah, I agreed. I think there's an opportunity to not just say whether it was monitored or not, but to potentially provide some actual data if it is recorded. But on a large level, it would be difficult to implement. And hopefully, if we establish the importance of this, it may be something that is captured for future.
Right, and I think that's the intent. I will defer to the HA in future years as to the next iterations of the CPR Quality Award, because I think this is really the entry level of getting more hospitals involved in collecting this information and getting comfortable collecting this information. And as we move forward, ideally, we will then set into place, I'm just hypothesizing, ensuring that we get all three data metrics on depth and rate and compression fraction, so that we have the totality of data for each patient collected in a systematic way with a device, let's say.
Excellent, thank you. Well, we all look forward to hopefully qualifying for more awards, which in reality is because we want to provide better care for our patients and have better outcomes. And I think both of these are going to serve to push us forward to better performance and hopefully therefore better patient care, better patient outcomes. I wondered, Natalie, if there are any questions from the audience that you've received that we should be sharing with Paul.
Sure. One that came through was it's pretty general, but it's something that we're always looking at is besides rigorous adherence to AHA guidelines for cardiac arrest care and post-cardiac arrest care, do you have further recommendations for hospitals looking to improve their overall survival to discharge rates? Any certain policies you've enacted or other QI type work?
Yeah, I don't know, Natalie, if you have the emails of the people who are participating, but we did a study where we visited hospitals that were consistently in the top decile, with top 10% of survival rate for 3 consecutive years within Get With The Guidelines resuscitation. And we also visited hospitals that were consistently in the bottom decile. We were blinded during the site visits as to their performance, and we interviewed, on average, 12 to 20 people, stakeholders at each hospital. You know, the Code Blue director, the people involved in quality improvement, and there were clear things that came out in the hospitals that were consistently top performers. Top performing hospitals tended to have either dedicated teams or designated teams. What that means is a dedicated team is that team for that day, all they did was rapid response and codes. They did not have clinical responsibilities. Obviously, not every hospital is of a size that can have that. We had one hospital that had 4 dedicated teams that had no clinical responsibilities, but responding all day to rapid response and codes. They were a big hospital. They had 1,000 beds, but still they put the resources in to do that. Designated teams are teams that had people determine a priority at the beginning of the day, who the people will be responding to a code. You know, your designed Code Blue team. And the hospitals that tended to do better were people who chose relatively the same people participating in code teams on every day. It wasn't just any random nurse or physician participating in the Code Blue team. These were people who wanted to be in the Code Blue team, and so they built more expertise in terms of responding and providing resuscitation in an efficient manner. There were other things that were identified in terms of knowing your roles before you even showed up. So it wasn't just having the right people, but they literally knew they were going to do airway. When they get to the room, they would be doing the chest compressions. Some hospitals had people doing chest compressions who were, if you will, professionals in doing chest compressions. They limited the people who could do chest compressions to people who were very experienced, because it's probably the most important intervention before anything else that happens. And why would you want anyone else but somebody who is very proficient in doing that? Hospitals that did more data review on a more frequent basis of their Code Blues tended to have higher survival rates as well. And there were other things that we identified, like having a very dynamic resuscitation champion to really put on the hospital administration's dashboard that this is a high priority. It's not just AMI, it's not only pneumonia and infections, but it's also cardiac arrest because it affects so many of our patients in the hospital setting. And so there were certainly other structural things in terms of a hospital that made resuscitations go better and delivered more efficiently.
I think that's a fabulous point about the physician champion. We hear from so many of our sites that having a physician champion means that they have the resources to abstract data, to get out there and be, you know, retraining maybe step down nurses who don't remember putting a backboard on or who need some more IV access training. And there's no shame in that. If you don't do it every day, you know, let's get them retrained, and that level of comfort really improves things. But again, yes, getting it on everyone's radar so that it's not just falls that we're looking at is key.
And one of the other things that came through was when we do simulation mock codes, doing multidisciplinary mock codes. It isn't just training in isolation. You're not just there with a dummy, but you're there with the whole team. It's like the pit crew mentality for out-of-hospital cardiac arrest. You want to practice closed-loop communication with the nursing staff. You have to practice communication in general, and then nowhere is it more important in an emergency such as in-hospital cardiac arrest.
And we are all so grateful for those physician champions or clinician champions, as the case may be. So thank you all. Monica, there was another one that I was going to pull out unless you wanted to jump in with
Please
something
go
else.
ahead. Please go ahead.
Someone asked about the consideration of length of stay in the restandardization model and whether that was considered as a variable.
We did not consider that as a variable. That could certainly be something that could be considered. You know, we could certainly look at it and see whether or not it falls in the model. We didn't think that that was going to play as large a role. And part of the challenge, of course, is that I think we had done an analysis on length of stay before the in-hospital cardiac arrest in the prior iteration with a fellow. There was some missing data as well. So I think that ideally that could be considered, but the survival rates are definitely going to be lower for patients who've been in the hospital for 2 weeks, let's say, when they have that, because it just indicates a worse illness severity. So it's an interesting proposition that we can perhaps revisit.
Excellent. So one last question, Paul. Now, given your success here, the holy grail, which is survival with good neurologic outcome, do you think that will ever be possible to model?
We would love to do it. The main challenge is 15 to 20% of survivors are missing that information. So that creates a huge problem because then you have a missing detail. We can't exclude those patients if we do an analysis, because a good way to think of why we can't do that is, let's say you have 100 cardiac arrests, in-hospital cardiac arrests, and 25 of them at your hospital survives to discharge, okay? And let's say out of those 25 that survived to discharge, 19 of them have discharged CPC information. If we exclude the people without discharge CPC, then you're only dealing with 19 survivors out of 94. And your survival rate artificially decreases from 25% to 20%. And so you're actually creating a problem for each hospital. And some hospitals have higher missing rates than others. So then I can't make heads or tails of what it's really hard to suggest imputation, especially if the rates of missing discharge CPC varies from hospital to hospital. If all hospitals submit for all the survivors discharge CPC, we can do it. And it would be great, because that's ultimately the like you say, the holy grail. We want to know if patients are leaving the hospitals alive without severe neurological disability.
All right, thank you.
Fantastic point. Everyone, please abstract your CPCs. In the new IRP, there is actually an auto-calculated formula on the admit discharge form that will show that delta in CPC from pre-arrest to post-arrest. So yes, the more data we can get on that for CPCs and for PCPCs, the better, 100%. Well, I would like to thank you both, Dr. Chan and Dr. Kleinman, so much for just a great presentation, wonderful engagement, and your dedication to the American Heart Association. To everyone for joining, thank you so much. After the webinar, as I mentioned, you will receive an email with a follow-up survey. We really appreciate your feedback through that survey if you have a minute to fill that out. In a couple of hours, you'll receive a link to the recording of the webinar. The slides are in the handout section of the control panel. And on behalf of the American Heart Association, Dr. Chan and Dr. Kleinman, thank you for joining us and have a lovely rest of your day.
And for others on the call, I just want to make sure you know that you have made all of this possible. The data you collect, the leadership you provide is really the foundation for the evidence that we've been able to generate. So thank you.
Thank you all.